Yeah, I was just going to say, shout it out. If you're joining us today, let us know in the chat where you are coming from, who's in the room, all that kind of good stuff. I know I'm in Vancouver, and for us, it is freezing. Comox, I bet you're socked in just like me. Welcome. So yeah, let's get started a little bit. I'll start with some of the intros and our housekeeping pieces, and hope that Dr. Wharton slides in as we do. So welcome you guys to this episode of Connected Conversations, the first point of contact, obesity management in primary care. Our guest today, is going to be Dr. Sean Wharton. He is an internal medicine physician and obesity and diabetes specialist in Ontario. Over the course of these series of connected conversations and webinars, we've really dug into a number of important topics related to obesity management, including the discussions we've had about those different pillars of obesity management from the clinical practice guidelines. However, many of these discussions seem to have taken place in a bit of a silo, and we recognize that. Ian and I have talked about that a fair bit, saying, each of these feel kind of one note, but we know how complex reality really is for many of us living with obesity. And we recognize that we mentioned how complex obesity is and that it's this chronic disease, but we really haven't slowed down to explore just how complex obesity management can be, or how interconnected all these different conditions can be. And I'm sure there are many people who have joined us today that have lived this experience and are excited to see themselves reflected in this conversation as well. So excited for that. So we know we have many community members that are reporting how obesity plus, and that means that you have those related conditions like diabetes or hypertension, sleep apnea, PCOS. There's many more that we can touch on. So we're excited about this conversation and see how obesity management can be impacted by some of these other conditions, how treatment for those other conditions may impact your obesity management, and how someone working in this space, for those of you that might be joining that are healthcare practitioners as well, hopefully arm you with some ideas on how you can kind of approach those complexities. So no small topic, and a perfect conversation to have with Sean, when he arrives. Oh, I'm just catching up, everybody. Argentina, oh, you must be warm. I'm so jealous. Ottawa, excellent. Northwest Territories, Ontario, West Virginia, yay. Oh my gosh, I love it. Thank you guys for shouting out and joining us today. For anyone who doesn't know me, I will properly introduce myself. My name is Lisa Schaefer. I am a patient advocate and a volunteer here with Obesity Canada. Connected Conversations is a monthly series, or we endeavor to try and make it monthly as much as possible over the last year, brought to you by Obesity Canada. And really in these conversations, we really wanted to have human interactions and dig into these important topics for those of us living with obesity, and connect us with the experts in this field, and also connect the experts in this field with each other as well. So from advocating for access to evidence-based treatments, issues related to diet culture, weight bias and discrimination, innovating obesity care in Canada, we really hope these connected conversations have addressed the complexity of the chronic disease and the barriers that those of us living with it face. So as I said, I'm a patient advocate. I'm a member of the patient community. It's been my joy for the last 5+ years to be volunteering with Obesity Canada and working closely with the Public Engagement Committee, working on advocacy for the millions of us who, just like me, live with this disease that is really highly stigmatized, really misunderstood, often misrepresented, and in my opinion, needs more light and shine and more conversation. And I get to do that work very closely with my dear friend and colleague, Dr. Ian Patton. Dr. Ian Patton, do you want to introduce yourself for a moment?
Sure. Thanks for that, Lisa. So I guess my role here with Obesity Canada is the Director of Advocacy and Public Engagement. So I'm responsible for a lot of the public-facing education, and I manage our online community that we have for people living with obesity. And I'm myself someone who is also a patient advocate myself. So I'm like Lisa, I'm very passionate about advocating for better access to care and reduction of weight bias and those sorts of things. So I'm really happy about having these conversations that we've had over the course of this year through Connected Conversations. I think we've hit on some important topics. Just a reminder, you can actually go back and see all of those previous webinars. They are recorded and available on the Connected Conversations website. I'll post the link in the chat. For today, when Sean does get here, he should be here momentarily. Just let me check something here. We will have the chat feature available, so you can connect with us through the chat. If you have questions, you can utilize the Q&A feature as well. You're able to upvote the questions that are up there, so you don't have to post multiple questions that are the same thing. So if someone else posts a question, you can click on it and upvote it so it comes to the top of the list, and we'll try and get to those questions as we answer some of these questions that are going along with this topic. I think with today, it's an interesting way to kind of end out the year in this series that we've done so far. To talk to Dr. Wharton, who you'll find out is someone who was one of the co-leads on the clinical practice guidelines. He works in this space very closely, and he's got a lot of knowledge around this. But like Lisa said, we've talked about a lot of individual pockets of obesity management, and being able to connect the dots and kind of take it even a bit farther and talk about how complex it is and how other conditions can impact obesity management, and how obesity management can impact other conditions. I hear a lot of our community members talk about things about, they've gone to their doctor and it seems like their doctor or their healthcare team has prioritized one condition. They're not going to address obesity management because they're too busy worrying about something else. In some cases that might be a valid approach, and in other cases it might not be. And I think Dr. Wharton would be a great person to kind of have that conversation and how he would address some of those things, given the knowledge that he has and the stuff that he's worked with through the years here in this area. And also kind of just building off of what we talked about last time. We talked about we're kind of at a tipping point when it comes to obesity management, with the innovative treatments that are coming out, and there seems to be a little bit more acceptance and understanding of obesity as a chronic disease. And there's more people that are getting educated, more health professionals that are, specializing or getting, certification in obesity management. And it seems to be getting taken a little bit more seriously. And so we need to understand how that works with complex health, which, nothing happens. When we're talking about chronic disease, nothing generally happens by itself. There's usually other things that are connected to that. So I'm really interested.
It can be really overwhelming, as well as that patient trying to keep track of all these different threads and the different conversations. So I know my stance is often and always very human focused, and really wanting to empower you guys, those members of the community that are in the patient community, to really have how to help you guys have a handle on these conversations and feel empowered and safe to use your words and ask questions during these moments. And that can be overwhelming enough just when you're talking about obesity in isolation, or really, in my mind, very rarely are we talking about obesity in isolation, because we talk about that. Do I care about my physical health or my mental health? So we know we've all got mental health handbag over here, our obesity handbag over here, and then we've got other bags that we need to pick up sometimes as well. So making sure that everybody feels confident in asking questions, connecting their care teams as well, can be really overwhelming. So I'm excited because I know none of this is simple. Life isn't simple right now, everybody. Let's be honest. We've got a handful of humans waiting on a very important doctor to show up as well. And that's what the world looks like right now. Let's be honest. It's not easy. It's not simple, but we can navigate it with grace and humor along the way as well, I believe.
Yeah.
I did also want to mention, while we are absolutely vamping and filling time, let's be honest, everybody, we did want to mention, though, in all seriousness, and I will say it again at the end, World Obesity Day is March 4th of 2023. And as much as I'm going, how am I already talking about March? How is it also already the end of December? But we're really excited. And in recognition of World Obesity Day this year, we will be holding our 4th annual Connected Conference on that date. And we're pretty excited. This will be a virtual conference. Yet again, we still are optimistic that at some point we will have a road show. And we will be able to come out and do this in human form at some point again. But for the virtual conference, we've got 6 hours planned with some pretty fantastic speakers. Again, really trying to connect all these different points around the pillars of obesity management and leveling up and really going, okay, guys, here's where we are. Here's what you can do, and give you guys, again, those tools, those resources. The Connected Conference is truly for the patient side of this conversation. And we also hope to talk a lot about advocacy on different levels, what that looks like for you as a person, being able to show up and hold your own boundaries. And then again, how do we go into those bigger rooms and ask the right questions of our physicians as well? So look for more information on that coming out. I believe January, we're going to start promoting the Connected Conference.
Yeah, we have the program pretty much set, and we have all the speakers approved and ready to go. It's just registration will start in January for that. If anyone here is a health professional, there's also our big scientific conference, the Canadian Obesity Summit, happening in May of 2023, and that'll be an event you don't want to miss. It's in Whistler, and the program and everything is starting to shape up, and should be an exciting time. So. Do you want to maybe do the little introduction of talk about who Dr. Wharton is? And
yeah, we can totally do that. I'm sure there are a handful of people in the room today that already know Dr. Wharton and will recognize him. Dr. Wharton has a doctorate in pharmacy and medicine at the University of Toronto. He's the medical director of the Wharton Medical Clinic, which is a community-based internal medicine, weight management, and diabetes clinic in Ontario. He is an adjunct professor at McMaster University in Hamilton and York University in Toronto. He's a really busy man. I also saw that he's been flying around the world a fair bit lately as well, if you follow him on the socials. He is also academic staff at Women's College Hospital and a clinical staff at Hamilton Health Sciences. Dr. Wharton's research focuses on bariatric medicine and type 2 diabetes. He is the co-lead author of the Canadian Obesity Guidelines. So he is very much a close family friend level connected person here at Obesity Canada. And he is a great friend of Ian and I, who is often willing to join us in these patient and healthcare practitioner conversations. Dr. Wharton is involved also in activism to achieve health equity in Canada. He founded the BMSA, Black Medical Students Association, at the University of Toronto in the year 2000. How was that 22 years ago already also? The BMSA is now a recognized mentorship organization across Canada, which is absolutely fantastic, because I'm sure he probably did that off the side of his desk as well. And as I've said, Dr. Wharton is definitely a friend to our Connected Conversations and has made an impact on many members of our community who have had the opportunity to hear him speak or seen some of his past contributions to our conferences, because he speaks the truth. He speaks at a very human level, and he is very empowering as well, I would say, as someone who's spent time with him. Definitely fuels you up and sets you up for nothing but success.
Well, look at the timing.
Look at the timing. Just as I finished pumping your tires, sir, you just slide in.
Zoom. There you go.
Zoom, baby. Zoom.
Zoom.
Literally, the next line of my script was, welcome, Dr. Wharton. Yay. Thank you for joining us today, my friend. So we've kind of warmed up the room a bit. I have given them the intro and given them your backstory, all of the good things, all the ways that we love you, your contributions to the Canadian Obesity Guidelines, all of those things. And we've also set the stage for today's conversation, which is about complex care and a place where I feel like you are someone who can cut through some of the noise and help us kind of see what's real. So as we mentioned earlier, obesity is related to a number of other conditions that can create a very complex approach to management for individual patients. So who better to chat to than the co-lead author of the CPGs, someone who's seen as a global leader in this area and someone who works closely with many patients to manage obesity and other complex issues. So before we dig in and make you talk about all these hard things, why don't we take a second, let you introduce yourself, join us in the room, and tell us about the path that brought you to obesity management.
Terrific. Thanks a lot, Lisa and Ian. This is great to be here. I was really looking forward to this and proud of the entire audience for being here during the Christmas season. And I think it's important. So we're obviously the field that I actually work in, but I think it's important during this time, particularly where there's vulnerabilities, there's challenges, there's issues around this season. So I think it's great. So I am a internal medicine doctor. So internal medicine means that I look at all the organs from the kidney to the liver to the lungs. And we are usually working in the hospital setting, working with acute medical conditions and chronic ones like type 2 diabetes and hypertension, obstructive sleep apnea. And I started to see all these things during my residency as oftentimes a complication of elevated weight, of toxic elevated weight, not regular elevated weight, the one that's causing the toxicity. And nobody wanted to talk about it. It was like a taboo topic in the room. One, because there weren't any treatment options or the physicians weren't good at the treatment options, and it raised a number of problems. So we just kept on medicating the medical condition with more hypertension drugs, more type 2 diabetes drugs. When I'm like, why are we talking about decreasing weight and toxic weight? So I went into that field thinking the fact that there was a discrimination involved in it. There's social aspects, and come as a Black man, understanding bias, discrimination, racism helps because that's those words. So prejudice, stereotype, and racism are the same words as bias, stigma, and discrimination. They're just one is used usually for racial stuff, the prejudice, stereotype, racism, and then the other ones are used for all the other discriminatory things that we do with people. We have our biases, the way we think about people, then we have our stigmas, which reinforce our biases, and then we have our discrimination. So it felt like a field that would make sense to me because I understood those things and I understood the biology. So that's where why I went into obesity medicine. And I think it works really, really well.
I love it. That's so human and real as well, to kind of recognize those different friction points and go, let's fix this.
Yeah.
It's easy to walk away from the tangled light of Christmas balls, right? than it is to kind of unpick them all.
Right. That's a good one. I like that analogy. I'm going to use that one.
It's true. It's what we're looking at, right? So I know, let's talk about obesity as that chronic and complex disease. So the Canadian Obesity Clinical Practice Guidelines, definitely we made some noise over there by using that revised definition of obesity that indicated that obesity is about much more than just someone's size or their weight. Obesity is a complex, progressive, relapsing, chronic disease where excess or abnormal adipose tissue impairs health. So to start, can you explain what this definition means and how this definition should be used in practice? Because I think what I just heard you say as well, looking historically, you saw people medicating the medical issues, not seeing obesity as a medical issue. And potentially right now we're kind of bridging that gap.
Right. Exactly. I think we're bridging the gap, but even more so, what we wanted to do with that definition is not demonize weight. If someone has elevated weight, quote unquote, that whatever that means, because it's more normal to have quote unquote bigger body mass. What does that even mean? We were smaller previously in multiple years ago, and now we're all bigger. But if you're bigger without any toxicities, because it's not toxic adipose tissue, if it's in the thighs, if it's in other areas, not in the central area, and you don't have type 2 diabetes, then you just have a bigger weight from a genetic standpoint and everything else, and you're beautiful.
And body diversity is okay, everybody.
Body diversity is super, super necessary. It's not even just okay; it's necessary. It's part of our life. It's part of the ethnic variations that we have. We wanted that definition to recognize that we're not talking about all weight. We're talking about toxic weight, toxic central weights, usually central weight that's causing intracranial hypertension. that's causing heart disease and preserved ejection fraction heart failure, that's causing obstructive sleep apnea. That's what we want to deal with, because as an internal medicine doctor, I want to deal with the health problems. So if it's not causing a health problem, then you're coming to the wrong person. I'm not going to see you. I'm not going to see an African-American woman, a white woman with a BMI 32 who's perfectly healthy. I don't have a treatment for her, because she doesn't need a treatment. She needs to be continued to be recognized as a sensational person. If she doesn't want to gain extra weight, then she can work on other things. But I'm an internist. So getting now going to that definition then told us that if you have that toxic adipose tissue that's causing toxic problems, it should be recognized by your medical team as something that should be addressed and can be treated, and you're worth the treatment. You're worth getting the treatment in terms of your own reasons why you should advocate and fight for it, because you're worth it.
100%. And I love that. And I think it again reflects a lot of I'm going to use the word trope, even though that doesn't sound kind or a good word right at the moment, but it's the word in my mouth, that there is no one cause and there is no one cure when it comes to obesity. And as well, that not all, and I think you just said this as well, but just to say it again, not all people in bigger bodies necessarily have obesity as this clinically defined moment. And also not everybody in small bodies necessarily then are not obese either, because we know that there can be fatty liver disease, those kinds of moments where it's not necessarily adipose tissue that is socially recognized, I guess I'll say right now, but could still be a very valid condition for people in smaller bodies. Is that correct? Am I following along?
That's very correct. And that's why we look at different ethnic groups, particularly the South Asians and the Asians. So they may have a BMI of 24, and that's BMI is just a number. So we won't demonize BMI. We'll demonize BMI cutoffs. Cutoffs are the bad thing, but the number is the number. So I'm using that number of 24, which for a white European male would be we have a definition for and what it ends up looking like. But we don't have these great definitions for the rest of the rest of the world until more recently we started to have an understanding of it more so. That BMI in South Asians from India, Pakistan, etc., that could cause fatty liver. They may need to have lower weights of around the BMIs of 22 range to not have a fatty liver. So quote unquote, if you had that BMI of 24, 25, and you had fatty liver, you would be considered to have obesity and you would need treatment. If you happen to be a big South Asian person, and everything was okay, then everything was okay. So to some degree, we look at it for big population stuff. But when a person's sitting right in front of you, I don't use BMI. I use more so an assessment of the person. If they've got a tiny little legs and a big belly, I don't care what their BMI is. I'm going to likely ultrasound their bigger belly to see whether there's fat in the liver or there's other toxic problems, because that's usually toxic tissues. If they have bigger legs and bigger waists, bigger hips and everything else, what am I ultrasounding? I don't. They have a normal size waist. I'm not ultrasounding anything, because there's nothing there that their waist circumference is not elevated compared to the person's hips. So I'm not ultrasounding their belly to find toxicities. I can do blood work assessment. I can do their blood pressure. I can do other things as well. And then look for medical conditions with the person in front of you, but don't assess just BMI.
Don't jump. I love it.
Don't jump. Yeah.
I love it. All right. So let's tangle into now adding more things to our ball of Christmas lights here, everybody, with talking a little bit more about those comorbidity conditions. Because I think that's something that's really important. And we often hear this out in the world. so we often hear it's related to other, that obesity, pardon me, is related to other conditions. Can you give us some examples of those relationships between obesity and those other common conditions that you see more often in your practice, and kind of how they play together, or how those two things bump in together? And I think we're talking about things like diabetes, PCOS, hypertension, but you tell us, what
Yeah.
do you see out there?
So this is good. So the question of, so there's a little bit of chicken and egg here. So is obesity caused by any other conditions? And the answer to that is, to a large degree, not really. We don't have a lot of other conditions that causes obesity. It can be caused by some mental health conditions, but it's mainly caused by the genetics. And that wouldn't be a condition, it'd just be your own genetics in this environment, in the environment of 2022, of that where your body is supposed to absorb as much energy as possible. And we have the comforts. I've got air conditioning here. We have heating. We have cell phones. We've got running water. We've got things where we don't have to expend energy. In that environment, which we're not giving up. We're not giving up running water. We're not giving up cell phones and air conditioning and stuff like that. That promotes elevated weight on a genetic background. So the next thing would be, when you get to toxic elevated weight, it causes many things, from the incidence of higher risk of complications from COVID, or even getting COVID. So acute medical conditions, and it causes the chronic medical conditions, osteoarthritis, obstructive sleep apnea, type 2 diabetes, hypertension. How it causes all of these things, we don't always know. The obvious ones are obvious. The mechanical ones. The ones, weight bearing down on the knees is obvious. Having urinary incontinence, where the extra abdominal fat is pushing on the bladder. That one's obvious. Obstructive sleep apnea, or hypopnea, where you can't expand your lungs. So if you have a bigger belly, it's pushing up, and your diaphragm needs to drop to open so you can take in air, right? Whenever you breathe in, you drop your diaphragm, you take in lots of air. If you can't drop your diaphragm because your belly's pushing up on it, you can't breathe quite as well. You're having shallow breaths. Those mechanical ones are easy to understand how the weight causes a problem. Other ones, like type 2 diabetes, we don't exactly know. It's like, why is the pancreas dysfunctional with this toxic adipose tissue, which sends off messages? So we believe that the toxic tissue sends messages to these different organs that cause a medical problem. What are these messages that it's sending to the different organs? There are messengers. They're called adipokines. So adipose is the name for the fat tissue, and cytokines are the words that we used for toxic messengers that cause inflammatory problems. So we combine those two words, adipose and cytokines, to call them adipokines. And they send messages to the brain, to the heart, to the kidneys, to the liver, to do bad things because they're trying to protect the body, but that protection turns into a negative reaction of those particular organs. So that's our current understanding of it. But again, we're working on the science to understand that interaction.
I love all of this. Sorry. Can you see me writing all my notes down? I'm like, don't even know how to spell it, but I've got my phonetic spelling. I think that's so fascinating. And again, as the one who likes to anchor it back to humans and the people I know who are living their lives right now, and things that I would have liked to have heard, a lot of that intervening on those toxic adipokine messengers is nothing that I'm going to achieve by running on a treadmill or managing every calorie I put in my face. I want to be healthy. I want to be active. I want to be mindful of what I'm eating, but my behaviors doing those things aren't going to make those toxic messengers go, oh, I should stop.
Right.
Is that true?
Right. So what it sometimes they can help to balance those, but it's so short term. that it ends up being a challenge. You can't spend all day on the treadmill because everyone online will read research that says activity is going to make all this stuff better. And that's true. It does. In the research, it does. And it does it every single time. It always does. It's never a different result in any of the actual studies. But the problem is they've never done those studies with people living with obesity and depression and challenges in their social condition and try to keep that for not 6 weeks, not 6 months, but years, 6 years, 10 years. It's hard to do. And we need more than just the simplistic, do this activity and your toxic markers end up getting better. No. I know that. How do I do the activity consistently when I twist my ankle, when I get sad, when there's social conditions, when I have to go to work, when how can I stay healthy even when I can't do this thing that makes everything better. That's our challenge with it. And that's what we debate with all the podcasters who like just hammer in. Look, exercise studies show that this was so great. I know. Thank you. Try to tell that to the Louisiana woman who is stricken with poverty and has too many kids from a lack of education and a number of other problems and is not recognized as a human being in her own country. You try and tell me, you're trying to tell her that this study at Harvard with
gonna fix it. It's all good. Plus, let's give her another, comorbidity as well. Like that's just so overwhelming.
Yeah.
So talking about that kind of human that has a complex comorbidity that requires and deserves the same kind of time and attention and care as obesity. In your experience, what can impact in your experience, what can the impact of obesity management have on those other conditions? And to that end, would you consider effective obesity management? Like what is that? Is it that I need to lose 100 pounds? Is it that I'm getting my markers followed? Is it like, help us paint that picture a little bit, if you could, if that made it sense.
Right. Yeah. No, that is absolutely perfect. So what does it look like? So we talked about all these conditions, these adipokines and these conditions causing problems. So what do people do about it now, or how does it make it better by actually doing this long-term treatment? So the idea is that the education about the fact that there's toxicities is important, so that the patient knows, and that now that the individual, the patient knows, they know that anything that they can do to stay on track will be a better day, but they should never end up beating themselves up about it if they don't at a certain time. So things went south for them. They twisted their ankle, their family member got sick, is in the hospital, and they've got to watch them, and as a result, they can't exercise. That shouldn't be the end of their story, because now they're majorly screwed, let's say, and can't do anything. We should have interventions that can help that person even when those things happen. And those interventions include bariatric surgery, medications, and cognitive behavioral therapy. The cognitive behavioral therapy is a harder one to scale. It's maybe a little bit of a harder one to do, but it works out very, very well. If you can get it, it works out well. Easier things to scale are medications. So the medication keep the hunger down even during the bad times. It makes it easier even during the bad times. It makes it easier in the good times, it makes it easier in the bad times. So when people come to me, usually their first visit, it's a good time. They've been able to make it to the visit. They're on track with a bunch of stuff and they're motivated. So I have usually an easier couple first visits. I'm not really worried about them in the first and second, third visit. I'm worried about them 6 months later or a year later when something goes south in their life and they don't show up to the visit. When they don't show up to the visit, they should have a treatment that still works for them. If they're not showing up to visit because they're sad, things are going south, they twisted their ankle. If I just gave them a diet and exercise, they're going to fail. But if they had a medication or they had bariatric surgery, even when things are going poorly in their life, they've got something that holds them up and keeps them going during that challenging time. I'm not a religious person overly. I'm celebrating Christmas, but I like the analogy if I'm going to give you a religious one, a religious analogy, there's that, everyone's seen that, where there's a person walking through life, and it's footsteps on the sand, and then there's two footsteps, and it's like the person and Jesus or whoever walking together, and then all of a sudden there's just one set of footsteps, and it was a really difficult time in the person's life, and the person goes like, why did you leave me during that time? I was walking by myself. And Jesus says, or whoever says, whoever she is, God, whoever she is, said, I didn't leave you, I was actually carrying you during those times. Those were my footsteps carrying you as you went through that difficult time frame. That's the way I see medication, bariatric surgery, cognitive behavioral therapy, and a good physician being there to carry you during the bad times. The easy time is the easy time. You're on track, you're feeling good, you're working out with a trainer, everything's going well, there's money in your life, etc. It's the bad time that I really want that person to do well. And that's why we work so hard to make the science and the biology make sense, and the surgery, the medications, and cognitive behavioral therapy. They make sense because bad times are coming for everybody, and you need to be supported.
I think that's a good point, and it's something that I point to. There's an image in the clinical practice guidelines, the pillars image, that shows those three pillars: the surgery, the cognitive behavioral therapy, and medications. And those three pillars are holding up the behavioral stuff, so the nutrition and the physical activity and all those things. So I think that's, it's a really good visual representation of how those pillars actually support those behavioral things. And we've talked about it before, those behavioral aspects of obesity management are important parts. They're not something that we want to discredit, but they're important parts for any chronic disease. And having these effective treatments is important. And another interesting point there. I appreciate that one.
Yeah, it's the first time I used that analogy of the the person being carried.
That's really valid. That's really big, though. And yeah, no, I totally resonate with that.
Yeah, that's the reason why we built it like that, with the pillars and the rooftop. I really wanted it to be a rooftop of supporting. And I remember the first time I drew that picture, it was, I was sitting in some restaurant, and I'm like, there's something wrong with the old pyramid, and I know that I can fix it, but I'm like, whoa, wait, so it came to me, and I'm like, this is it, I got it.
I love it. So when it comes to managing those other chronic conditions that might bump into our pillars or make pillars have to wait, might be a better way to say this. What is your experience, or what have you seen in that regard? So is it that we should, and maybe this is shockingly, maybe it's individualized care, Sean, is the answer, which is often the answer. But is it, should we be focusing on the obesity treatment to get relief over in the hypertension world, or should we be focusing more on the hypertension and do we see obesity finding relief when we treat comorbidities in some cases? What does that look like in your experience?
Right. And so this is a great question, because as an internal medicine doctor, again, my job is to look at all the internal organs and the connections with them, but even just the individual organ, and just treat that. So I don't ever look at one treatment treating the other things and waiting for that necessarily. Sometimes my patients want to wait, and that's okay. I'll go with them on that. But my idea is to treat all of them. So if you have type 2 diabetes and elevated weight, I'm treating your type 2 diabetes. I'm a type 2 diabetes doctor. I'm going to put you on type 2 diabetes medications and monitor them, etc. If you have high blood pressures, which is where I started, my field of medicine was in hypertension because it affected the Black community, and that was my research field. I wanted to go into that. So I will definitely just recommend that you go on high blood pressure medication, because it decreases death and stroke. And we're still working on the weight management. Yes, I agree. The weight management will help the high blood pressure, but I'm recommending high blood pressure medication to decrease your risk of having death and stroke, because your high blood pressure may be a genetic thing. Maybe people who are 120 pounds have high blood pressure also. So, and then yes, if your weight comes down with the medication, with the weight management medication, with the bariatric surgery, with the cognitive behavioral therapy, and your blood pressure gets better and better, we stop those medications. And then we're able to, and you're able to maintain a healthy blood pressure without the medications, then I stop them. So you're not doomed to be on these chronic disease management medications for life if the weight can come down and work out great. But so that's how. So I don't feel that they bump into each other. I believe that they work all in the same time.
Mhm.
And many people want to do a reductionist viewpoint of a bunch of things, like reduce everything to just one problem, and then you'll fix that one problem, and then therefore everything will end up getting better. And I'm like, well, unfortunately, that's not the way it works. It's complex. It's a complex interplay. As a result, it requires a complex answer. And I have to apologize sometimes to them that it means that we've got to work on everything, and we have to work on the complexities of everything. I'm sorry that it's a complex answer. It's not an easy reductionist answer. You just do this one thing, you just go on this keto diet, and your world is going to be sensational. No, it's a complex answer. It deals with your genetics, all of the disease states, the chronicity of it, and the fact that multiple treatments may be needed at the same time.
I think from a patient's perspective, a lot of us, at least in our community, a lot of people will say like they go to their doctor and they're getting treatment for something, or they get diagnosed with something, whether it's hypertension or diabetes or something like that. And it's always like a little throw on at the end. Oh, and by the way, you should probably lose some weight, right? Like it's just a little add-on, right? And they're left with nothing to, actually, actionize that recommendation. And so I think that's part of what we'd like to get at. And I think it was interesting, last month I was at the Diabetes Canada conference, and a lot of the presentations that I saw, they were actually talking a lot more about obesity management, clinical effective obesity management, not only being part of that key part of type 2 diabetes management, but also being a bit preventative, right? Like stopping people from going from pre-diabetes to diabetes. And so we need to look at, effective obesity management earlier on or farther upstream, and be interested in your thoughts on that. Because I think we're at a bit of a tipping point here where we're seeing a change in how we view obesity management.
Yeah, and I'm hoping that the internal medicine. So because I'm a weight management doctor and an internal medicine doctor, I'm definitely always doing both. I'm definitely going to do the hypertension. I'm going to do treatments for their type 2 diabetes, and I'm doing weight because I'm interested in weight management. I think that the hypertension doctor and the type 2 diabetes doctor should come to my camp as well. And as you said, not just do that weight management as by the way, you should also lose a bit of weight. I'm treating your hypertension and your blood pressure, but you should also lose a bit of weight. No, make it a focus and do a good job of telling them how to get weight off, toxic weight, because the toxic weight is causing the condition that they're treating. How to get rid of that toxic weight and keep it off over the long term. Don't softball it, but give it the appropriate attention that it actually needs. And I see there is a question in the chat group as well.
Yeah, there's a question here, and I guess it kind of gets to what we talked a little bit about earlier with the new definition of obesity and stuff like that, and that it's not all just about BMI, but it's about, what do you think about the metabolically healthy obese individual?
Right. So metabolic healthy obesity, is it a real thing? So essentially what this is asking is somebody who has a elevated weight, let's put it as a significant elevated weight, BMI of 40 or something like that. Is it possible for them to not have any metabolic health conditions, not have pre-diabetes, pre-hypertension, osteoarthritis, et cetera, And the answer is yes, it is possible. And we've looked at the data, and it's about 5% of people with a BMI greater than 40 do not have any actual medical conditions. So it's not a lot of them. 5%. So 95% do have something. So I'm hoping that we can move away from the discussion about it as much as we have. People are fascinated by it, when in fact it's not so fascinating to some degree. What's more fascinating is why we need to spend more time investigating our patients properly. Anyone who's in front of us as a family medicine doctor, internal medicine doctor, do their blood pressure, do their blood work, find out their family history. What genetic risk does the person have? And if they're healthy, the person's healthy. If they're not healthy, then they actually aren't. The question of why somebody with a BMI of 40 could be healthy. How did that 5% stay healthy? And that is a good question. We don't exactly know. But just like we don't know all the reasons why the toxic adiposity causes the unhealthy aspects, I don't know exactly how the person protected themselves. Most of the time, what we see is that most of their weight is not in their central area. They're big, but their weight is in their thighs and their hips and their buttocks area, and a lot of muscle. And the amount of brown fat to white fat makes a difference. They have more brown fat. They have more of the protective fat, and they don't have as much of the toxic fat. That's what we generally see. That's not the only answer. Their genetics are a big part of it also. But it's probably too hard for us to answer now, but I think it's a fascinating topic.
I think some of the fascination with that topic is, a lot of it centers around weight bias and stigma and how patients have been treated in, healthcare, and they don't want to have those conversations because they've been so bad in the past, and they feel attacked and those sorts of things. So they're like, I'm here to talk to you about something else. It's not about my weight. Leave me alone. I'm perfectly healthy. Nothing's impacting my health right now. I don't need to have a discussion about my weight. And so I think there's an element of that in there as well. And I as you were talking there's something that jumped into my brain. It was another conversation. I was on a ad board or something like that with another doctor who took a bit of a different approach to what you said. And, it said it was a small percentage of people that are metabolically healthy and have elevated BMI and stuff like that. So his approach was more like, if they come in with a high BMI, I'm gonna, statistics dictate that I should be, approaching obesity, and I should be bringing this up with them, and I should be treating them for their obesity, because if they aren't sick now, eventually they're going to get sick, was kind of the take that he took on it. And I was like, it's a little bit more nuanced than that. There's a little bit more soft gloves approach that's probably required for that. And that approach is probably what turns a lot of patients off.
Right. That's a good point.
That's interesting.
That's well stated. I really like that, what you just said. And I think that doctor is biased, is stigmatizing patients and not giving them the benefit of an investigation.
Yeah.
Like someone comes in with a BMI 42, I don't know if they've got how bad whether it is bad at all, whether there's anything going on. I need to do the investigations that I would normally do in someone with a BMI 27. Someone comes in with BMI 27, I do their blood work, I do their blood pressure. If they've got disease, they have disease. I should do the same thing here, not assume that the person is and we have the capacity. If we were in a world where we had no capacity to do blood work because we had no money and we had to do just one indicator, then you could almost say that would make somewhat of a statistical sense. But we don't have to do that, and we do have the capacity. So I think that we should be much more sensitive.
So fascinating. It's also a reflection, I think, of what a young science this is also to a degree as well. We are still all learning the language, figuring out what our common language is, what are the guidelines that we should all be following in those moments. So I think I also appreciate hearing we don't know enough. And I think it's perfectly fine to hear that from healthcare practitioners. I would rather hear that from a healthcare practitioner. Like, this is what we know today. And when we know more, science will tell us more and we'll go there. But for what we know today, let's start here, I think is a very healthy and transparent place for people to be. That's my side tangent on
Terrific. I
that.
like it. I like it.
I do want to go back to one comment that you made, though, Sean, because it's banging around in my head. And I just want to clarify. So when we were talking about those comorbidity moments and taking medication, this is one that I wrestle with in my noodle a little bit as well, as someone who has now been managing my obesity effectively for a few years. I am thinking of it more like my glasses. That my eyes haven't improved over the years, but I still wear my glasses without feeling like I'm doomed to wear glasses. Should we not have that same approach when it comes to some of these obesity medications for where we are today and what we know today? I shouldn't be thinking I should be titrating off of necessarily my obesity medication. And I bring this up because you mentioned that doomed to take medication when we were talking about hypertension. And I just want to clarify, because I think what you were saying was if the hypertension is being resolved, we can explore removing those medications.
Right.
I just wanted to go back to that one for a second.
Thank you. Yes, that was important. Are you doomed to taking the high blood pressure medication forever, which would not be the worst thing to actually do. But if you could get the weight down, and we know, and keep it down, because we know if that's what is affecting the high blood pressure, not your genes and your genetics and other things, that environmental, then you could come off of the high blood pressure meds. If you had a bad family history of people having heart attacks, even at lower BMIs, et cetera, not toxic, then I wouldn't come off of the high blood pressure medication, because there's a protective, the protective E effect there. Now, you were talking about how long do you stay on the medication? Do you titrate off? And I was on a panel where John Wilding came up with the Arya Sharma moment. I'll call it. Arya gets these great anecdotes or word or concepts that he comes up with that really make a difference. Where somebody in the audience said, for the whole panel there, isn't it just, it makes it easier for these patients to take medications, and doesn't it just make it, isn't that kind of cheating? It's easier for them, and therefore, as a result of that, they're not going to try hard. They're not going to try as hard, and isn't that a problem? This is at a big international conference. Someone actually asked that, and it was great, right? It's great when you get questions like that. Otherwise, you just hear this echo chamber. So it's really nice and John came up with the greatest answer. I'm so proud of him. He goes, you just said that it makes it easier. And he's like, that's right. It does make it easier. And that's exactly what people should always say. It makes it easier for me. And I want that easy. I deserve that easier. The same way my cell phone makes it easier for me not to have to do a rotary dial and to be able to
remember every phone number. Oh my gosh.
Yeah. Why wouldn't I want it easier during the hard times, during the easy times, the easier times? I want it easier. Thank you very much. And so therefore, if you take this medication away from me, you'll have to fight me for it to take it away. I want it long-term. I want it for the duration. And whatever highest weight I got up to is where my brain wants me to go back to. So therefore, I have to keep my foot on the gas, regardless of what's going on in the world, what's going on in my life. My foot still has to stay on the gas, even though a bunch of things in my life are causing stressors and everything else. I still got to put my foot on the gas for keeping the weight down. Therefore, I'd like it to be as easy as I possibly can, because I've got self-esteem and I've got willpower and I've got fortitude. Because the idea is that when people say you need to come off of it, it assumes that you didn't have enough willpower or fortitude or constitution, and you just needed the medication for a little while you bolstered up your willpower and your better behavior and capacity. Like it wasn't good before. It was always good. It was always sensational, better than many people who are at a lower weight. And the medication just now made it available for you to be able to actually actualize all of that willpower and motivation. It was never low. It was never a problem. You never had bad constitution. So people who say you should stop are telling you that you did not have good enough constitution and you finally got it together. Therefore, you can come off of the medication. That's such a stigmatizing and biased message.
Hell yeah. Big ups for that. Thank you. Yes, because I think that's a huge part of this. And I know for myself, I always just frame for me, that's still part of my internal dialogue, even though I do this and I do this all the time. It's
Yes.
still the first place my brain, and then I sassy now. So I'm louder in my own head too, going like, slow your roll, Schaefer. But we need everybody to understand that moment is so important to me. But let's bring this home in the way that I always like to, which is to provide people with hope and resources. So let's talk about what success can look like
Lisa,
here. Mm-hmm. Are
sorry,
you interrupting me?
I wanted to jump in real quick because
You're allowed.
to speak to the title of what we were talking about with this webinar is how conditions kind of impact obesity management and vice versa. I kind of want to just quickly touch on the vice versa because I know it's something that'll come up in the community. So we've talked about how comorbid conditions and obesity are related, but what about for individuals who have conditions that might not necessarily be related to obesity, but their treatment of those conditions can impact obesity? So like medications that cause weight gain, for example. How do you approach obesity management with something like that?
Ooh, thank you. Good call.
Yeah. So what I currently do is I still try to keep them connected, but siloed. What I mean by siloed is your mental health is important enough for you to continue to treat it the best way you possibly can with the best medications. If there's two best medications and one has less weight gain than the other one does, then great. But if there's a best medication and mental health is a big issue for you and it causes weight gain, it causes weight gain. Let's work on the other component of weight management, which would be put you on a medication, give you some cognitive behavioral therapy, have you manage. So we did a study where we showed that patients on antidepressants and antipsychotic agents that cause weight gain do just as well as those not on antipsychotics and antidepressants when they were part of a weight management program. So we weren't handcuffed by them using the antidepressants. They stayed on them. Their mental health continued to be good, and we bolstered them with all of our things that we can actually do. So I try not to get into those other realms and stop people's meds and et cetera, unless it's really clear that we can and we can substitute. But otherwise, I try to do the best we can with the two conditions, treating both conditions really well.
Yeah, good.
I like that.
Yeah.
Thank you. That's a good call. Thank you, Ian, for bringing that one in because it's very true. Not all things. Correlation, causation, relatability, all of those moments, right? So thank you for that. But let's go back to my chime in about, let's paint the picture of what success looks like. So as someone who works in obesity management, what do you look for in long-term success?
Excellent. So I look for a understanding of self so that the person actually understands, I believe you, Doc, that this is a genetic condition where the environment that we live in today, that's not going to change. And I like the environment. I've got air conditioning. I've got strawberries that are toxic and will kill me, cause dysentery and stuff like that. I've got safe things. I'm okay with this, but I know that environment causes obesity on top of my genetics. I believe you. This is thank you. And it's not my fault. I now know that I've got options for treatments, and those include bariatric surgery, which I may not be big enough for that, but I know that that's an option. But I'm at the right range for a medication option. And I'm at the right range for cognitive behavioral therapy, and I'm the right range for the new medical interventions, or I'm at a range for medical interventions. And I believe that it can be managed, and I can continue to manage it over the long haul. So that understanding of biology and self, and that I'm worth it, and that I am worthy of this treatment. I'm worthy of the bariatric surgery that's paid for by the government. And if it's not paid for in my province by the government, I'm going to advocate for it. I'm worthy of it. I'm worthy of the medications that are out there, and they should be covered. And I'm worthy of cognitive behavioral therapy to address my psychological profile. So that understanding of self allows treatment to actually happen.
And it might take more than one kick at this can too.
Yes, exactly. Exactly. That understanding of self understands the resilience. Fall off, that's okay. We're right here. And there are good treatment options, and you can get back up. Falling off is not the end of the story. It's the beginning of a new movement forward.
Nice. So what insights do you arm people with, like in early visits, so that you can start them on this journey and thinking about long-term success in that way?
It's a combination of what I just talked about, the biological understanding, the genetic understanding, but I don't leave them with that. I also introduce right away, there's effective treatment. You can start on it tomorrow. So success equals success. While they're learning to believe that they're worth treatment, that biology is important, genetics are important, the environment is not their fault. There's obesogenic environment is not their fault. While they're learning about all that, they also can get effective treatment today. Because it's different than 1985 and 1995 where we didn't have anything, and then they can start to see that there's effective treatment, and we're still thinking about all the other newer treatments that are going to come along, or all the important aspects of you being an individual, being loved and being cared for. So we can do all of it at the same time. You don't have to wait for just wait until you understand all the biology and all, and then maybe I'll give you a medication option, or the other way around. People come to their realization in different ways and different components. We can give them all the capacities, and then we can pick and choose and work with every person differently.
I love that. And one of the words I used to describe you was very empowering. And I think that's exactly what that moment is empowering that person to take action in their own health that they said they've been wanting to do, and probably have been doing, quite honestly, in the ways that diet culture has told us to do it, but give them that small win, like immediately out the gate of, I'm empowering myself to do something even more, and I'm going to see action and change. I love that.
Yeah.
It's hard. It's really hard. Those first conversations can be very, very hard, let alone when we're talking about compounding comorbidities as well.
Right.
Showing up for ourselves is not easy for, I think, anybody walking around on the planet, but I know what it's like living with obesity and walking around on this planet, and it does have an extra layer of complexity for sure. So is there any one takeaway that you want people to have from our conversation today?
Yeah, and the takeaway for me always seems to be it's similar. I want them to believe that they're worth the treatments, they're worth the time that we've spent on this seminar, they're worth the time that their family physician has put in and should put in, and that the government should put in. And whether that equals a treatment, such as a surgery, a medication, a CBT, or just a belief that they are important and loved and cared for and don't have medical conditions and just have a beautiful body. All of those things is what I want them to take away. So it's not a takeaway, you need to go on this treatment, but you need to believe that you are worth all of the everything that is available now within the weight management field. That goes from treatment to believing in yourself and understand that you deserve love and getting rid of bias and stigma. All those things are part of the weight management field, and they deserve that.
I love it. That is a fantastic takeaway for today. Thank you.
Great.
Ian, do we have any other questions or thoughts that we want to?
No, I think being
we're
mindful of Dr. Wharton's time. I know he's
yes,
got to
that
get
too.
back to work. So
I'm sure somebody's knocking on your door, sir. So we will.
Absolutely.
We will let you go.
But I was so happy to do this live. I really believe that live really works out well. And if people ever have questions that they send to you guys that they want me to answer as well, I'm happy to. And you guys do such a great job. So thank you very much.
Thank you so much for all you do. I want people to take away exactly what you said, and also take away the fact that amazing caregivers are out there that look like Dr. Wharton. And Dr. Wharton works very hard at setting up other people for success with his work in the clinical practice guidelines, the Caliber program, being open, being connected, sharing all of these insights and information. So thank you for the difference that you are making in the world, sir. It matters.
Thank you,
we
Lisa. And they
greatly
don't
appreciate it.
all look like me necessarily. Look at this hair. How many of them have? They don't all look like me.
This is what we want, more of
This is
this
what you
diversity
wanted in
in
this
the world.
seminar, some craziness.
I love
Have
it. Thank
fun,
you so
guys.
much.
Thank you
Amazing.
very much.
Everybody,
Happy New
all
Year.
the best. Yes, and to
Happy
you.
holidays. Happy holidays. Thanks.
Yeah.
Thanks,
Bye-bye.
everybody.
care,
Take
everyone.
good care. Be kind to yourself and at least one other person. And we look forward to finding you again in the new year. Thanks, everybody.